All right, cool. We'll go ahead and get started. Thank you everyone for joining us. We're excited today. This is the first of our Achieving Together conversation series, which will be big public broadcast conversations around different elements of the Achieving Together plan to end HIV in Texas. We're super excited today to have a couple of national speakers with us from Kaiser Family Foundation. The first is Dr. Yates, who's the Senior Vice President and Director of Global Health and HIV Policy for KFF, and her colleague Lindsay Dawson, who's the Associate Director for HIV Policy. I'll be giving us an overview of the national plan to end the HIV epidemic, where we are with that plan, and some of the strategies going on with that right now. So as we get started, as we go along, you will be muted, as I said. If you have questions, you can type them into the chat. And Lindsay, I don't know how you want, do you want to hold off until the end to answer questions? How do you want to handle questions?
Yeah, thanks. I think we'll wait till the end just because it'll be easier with slides and going through things, but we'll save enough time for questions for sure.
Okay, so yeah, if you have questions, we'll have a Q&A at the end.
Okay.
And with that, we'll go ahead and get started. I'll turn it over. I have your slides set up, Lindsay.
Okay.
Also,
great.
Just let me know as you go along.
Okay. Hi, everyone. This is Jen from KFF. Really excited to be here today to talk with you. I feel obligated. The first thing to say is that we, Lindsay and I, do not represent the federal government. We are an independent organization that does policy research on HIV and other health issues. And we, particularly at the federal level, and we've been tracking this initiative and writing about it and had a big event about it. So therefore, we think we could give you some insight into what is being said about it and hopefully answer questions. But if there are specific questions that you have for the federal government, we might not be able to answer those. But we'll do our best. Okay, so let's get started. So what we're going to just try to cover, what is this initiative and where is it today? What are the opportunities specifically for Texas? What could you be doing right now? Some of which you probably already are doing. What might be some things coming down the road? And then just a discussion a little bit about challenges that I would imagine many of you are already aware of and dealing with. And then any questions, we've identified some questions that are still outstanding, and then we'll get to your questions. So just to give some broader, you can go to the next slide, some broader context for, we think why this initiative was launched, for many reasons, but one is that the U.S., when you look at the U.S. compared to other comparable countries, is doing much more poorly by many metrics. In terms of addressing HIV. And here's just one. These are viral suppression rates by country. Can you all hear still? Okay. Viral suppression rates across many peer countries, and you can see the U.S. is performing the worst. We actually added Texas in there. Just press one click, it should pop up. Texas is doing a little bit better than the U.S. But as you can see, there's many countries in the world who spend, frankly, less per person on care and have much better health outcomes on HIV and other areas. So that's one challenge. The second, next slide. As you all also know, HIV incidence in the U.S., which had been coming down, which is a good thing, is now starting to stabilize. So we're not, as a country, we're not making further progress. And our epidemic is a concentrated one. It's really affecting certain populations in certain places. Again, none of this is new to you, but this is the context and the backdrop against which this new initiative was announced. So next slide. The other thing is, if you look at the trajectory of funding, federal funding for HIV programs, which is where the majority of funding, dedicated HIV funding, for HIV is coming from, it's been pretty flat. This is a combination of Ryan White funding, CDC prevention funding, HOPWA, other programs that rely on annual appropriations from Congress, every year. And just looking at the last decade or so, there's been some increase, but then it's really flattened out. So investments are not increasing, or had not been. Next slide. So that was the backdrop against which this initiative was announced, the Ending the HIV Epidemic Initiative. It was announced in February 2019 during the State of the Union address by the President. And as you all have seen, the goals are to reduce HIV incidence in the U.S. by 75% in 5 years and 90% in 10 years. It's going to be a phased-in approach. We're in phase 1, starting to be in phase 1, which the administration has identified 48 counties, including these 5 in Texas, DC, San Juan, and 7 states. The counties the counties in DC and San Juan account for half of HIV diagnoses. So really, where most HIV is in the country, that's the initial approach. And I think it's important from what we've seen that this really is, they are talking about this as a phase 1, start where most HIV cases are, focus efforts there, and then for phase 2, it would be a broader reach. But this is the phase 1 intention and rollout. Next slide. We have a lot of data at Kaiser, and there's a lot of data out there that you can all use that allows you to sort of look at the various indicators, and we just picked a few here for the nation, for Texas overall, and for the 5 counties that have been selected to be part of the phase 1 of the initiative. And here are just a few you can see, and I think some of these will be known to all of you. The share of the nation's HIV diagnoses, for example, that are made up by Texas, the share that are made up by the 5 jurisdictions, how many Ryan White grantees, or how many Ryan White grants there are, number of health center grants, and then some other measures that are maybe not so specific to HIV, but really matter, poverty rates in the areas, and probably most importantly, uninsured rate. And as you all know, the uninsured rate in Texas is significantly greater than the nation overall, and you can see those data here. But we at KFF have been looking at data like this across the jurisdictions, and will continue to over time to really try to get a better sense of what factors need to be addressed and considered to have the kind of impact that the administration wants to have with this initiative. Next slide. The administration has identified as part of the initial rollout that there are 4 pillars that they are focusing on: diagnosis, treating, preventing, and responding to HIV. Really the core, I mean, one thing I think everyone should know and hopefully has seen, the elements that go into this initiative that have been identified and are being focused on at CDC and at HRSA are the key aspects of the HIV response that are science-based and have been shown to have the biggest impact: PrEP, early access to treatment, scaling up the services that work. So I think that's an important point to underscore here, that the effort itself is based on what works, what has been shown to work, and that's critical. But they're framing it around these 4 pillars, and you can also see all of the federal agencies that are involved, with, I'd say, HRSA and CDC being the most prominent in terms of direct service delivery. But IHS, the Indian Health Service, is also being featured as a key part of the response for those parts of the country where there are larger Native American populations that have disproportionate rates as well. Next slide. So importantly, there are new initiatives announced at many points in administrations, this one, others, and often they're announced without necessarily new funding. In this particular case, the administration did announce through a budget request that it intended to ask Congress for additional funding, that is new funding above current levels. Here on this slide, you can see how that breaks out, but roughly $291 million new funding dollars for HIV, In the grand scheme of the federal budget, it's not much. In the grand scheme of HIV, it actually is significant. Here, we just break it down by the agencies, but if you go to the next slide, just to highlight two important points, you can see here the history of Ryan White funding and then the history of CDC HIV prevention funding. If the budget requests are to be met by Congress, it would mean, and click through twice, it would be a 3% increase at Ryan White and an 18% increase at CDC. And as of today, it looks very likely that this will happen. Both the House and the Senate just this week, have moved through bills that would fund at these levels for the most part. So it is looking very likely that this new funding will be made available. And just one thing to say about that, this funding, as you see at the top, is for fiscal year 2020. What that will mean is the new funding, if made available, will probably not be out into the field until the first quarter of 2020. So it's not imminent, but it is looking very likely that this funding will be there. So that's something important to know, and that's really, hot off the presses as of this morning when the Senate bill got posted. The Senate bill got posted this morning. So next slide. Lastly, for my part, and then I'll turn it over to Lindsay, while everyone is awaiting that new funding, because as I mentioned, that would be significant, and just one other word about that, I think the idea is not that funding amount itself is the total amount needed to end the epidemic in the United States. And in fact, the administration has said that they intend to ask for additional funding out of the further years out. But the idea is to jumpstart, to incentivize, and to really spark more investment and change by providing additional money. However, the administration said that they did recognize waiting to see what happens with that could take a while, and so they have already leveraged existing money from fiscal year 19 that was already appropriated, approximately $90 million to date, that they have taken from existing grants to help get jurisdictions prepared, some of which those on the phone may have already been engaged in. There's been money mobilized from the Minority AIDS Fund, which is a special amount of funding that sits at the HHS Office of the Secretary. That funding, $29 million, has been provided through HHS generally, as well as CDC and NIH, and happy to answer questions about some of that if people have them. HRSA, through the Ryan White program, has mobilized about $1 million to 10 Part A jurisdictions, including one in Texas, to enhance efforts and get sort of a head start. And then there's a pending funding amount of $60 million, which is much more significant, that will be new Part A and B funding, new Part A and B money through Ryan White to support activities. I want to flag that because that is due in a month, a little less than a month. It'd be interesting for us to hear if you all are considering that, but that seems to be an important opportunity. And with that, I'm going to segue to my colleague Lindsay, who will talk more about that and the opportunities that may be underway already for some of you, or you could be thinking about, and continue on the presentation.
Great. Next slide, please. Thank you all very much for having us. And as Jen mentioned, we're well aware that you're already working on these issues and thinking about these things. So we'd love to hear in the question period if there are things that you're also thinking about that didn't make it onto these slides. So first, thinking about opportunities for Texas. I think it's really important to think about where this initiative is coming from. That it's coming from the Trump White House offers an opportunity to start conversations about HIV and prevention in communities because it's a sort of big platform, but also in a place and in a way that local jurisdictions, states, and sort of localities may not have been able to have had in the past. And thinking about that local focus, the administration's really tried to make it clear that they understand that there are unique contextual factors that need to be considered when implementing and ending the epidemic initiative. And doing it this way allows for community engagement. So far that's been happening through listening sessions and plan development, and it allows plans to be responsive to local context. So that you have a plan that looks different in an area experiencing a lot of injection drug use than you do in a plan that is really struggling with the fact that Medicaid is quite limited for HIV patients. In addition, in encouraging jurisdictions to refine and develop plans, those that already have plans can really take stock and say, is this working? Does what we have in the plan really have the sort of components in it that's going to allow us to address our local epidemic? And it really pushes jurisdictions that don't have plans to sort of have those conversations with stakeholders and figure out what might work from them. Another key component here is the focus on providers and workforce development and really sort of bolstering capacity. So one way that's happened is through the provision of public health service corps officers that were deployed to 3 ending the epidemic sites, including Dallas. And there should be 3 officers happening in Dallas now, sort of working on those issues. And there's also workforce development happening through the Ryan White programs, AETCs. In addition to the overall technical assistance that the Ryan White program will be providing. Jen talked quite a lot about the funding, but of course the biggest opportunity here for jurisdictions is to actually apply for the funding. So the NOFO that's out now, that's due October 15th, really gives an opportunity to Ryan White grantees to use those funds in ways that might not be possible. There's a little more flexibility than the traditional Ryan White categories that are tied to A and B grants, and so can have sort of aware the fact that grantees want to use those dollars in sort of more innovative ways. And we also understand that there is a health center NOFO in the works, so watch this space for that. Next slide, please. Thinking specifically about Ryan White and health centers, in addition to what's happening at the federal level, it's useful to think about what grantees can be doing on the ground. So with Ryan White, a focus on rapid initiation of care and treatment can be really critical, in addition to expanding and re-engaging those who are out of care. And one way to do that is to leverage data sharing, and data sharing, of course, has sort of a wide range of applications beyond that. And in addition, taking advantage of those sort of learning opportunities to have, like the technical assistance and dissemination of the best practices that will come out of the pilot projects. In the health centers, some health centers already are engaged in HIV testing, and some can really sort of bolster their efforts around that. So really focusing on sort of meeting CDC guidelines around HIV testing will be important, as will doing community outreach and engagement, and making sure that those individuals reached through outreach can really get plugged back into either the health center or Ryan White programs. Another key opportunity, and it's really the focus of why health centers are a component of the Ending the Epidemic Initiative, is leveraging health centers for providing PrEP services and PrEP education. And one opportunity there is to use 340B dollars, and only about half of health centers are doing that right now. Next slide, please. So those were the opportunities, and now to talk a little bit about the challenges. Some of these are specific to Texas, and some of them certainly are not. Some of these are challenges that are facing the nation as we sort of try and understand what it's going to take to meet the goals of this initiative. So of course, Texas has not expanded Medicaid, and not only does that mean that individuals are uninsured and lack access to sort of the full range of health services they might need, but it also means there's a greater burden on programs like the Ryan White grantees and the health centers, and there's less capacity to sort of address some challenges that they're facing. The 5 Texas counties that are part of the initiative all have moderate to high social vulnerability index scores from the CDC, and this means that those counties may be less able to be responsive. So if there's an emerging outbreak of HIV or the opioid epidemic fires up in a hot spot, and so that's something to watch for. In addition, as a state, Texas lacks such orientation and gender identity protections for health insurance. And if the administration rule on 1557 removes some of those federal protections, not having the state protections could create a real hole for this population. We've talked a little bit about the opportunities to ramp up workforce capacity, and we know that that's a real challenge, especially in some communities where there just aren't enough HIV providers, and there's real concern that if we diagnose a lot more people and bring them into care, that we might not have the workforce to really meet everyone's needs as best as possible. Of course, Texas is a border state, and the immigrant populations in general are facing a lot of stigma and discrimination, but especially with respect to the public charge rule that's come out, which means that immigrants may not have access to Medicaid. And while the rule does not specifically target programs like Ryan White, there certainly could be fear and stigma in the community that makes accessing those programs feel more challenging to individuals. As always with federal grants, grantees are what their activities are defined by those grant perimeters. And so there's likely to be situations where you think, we're dealing with a lot of chronic homelessness and housing instability, and that's the real issue in getting individuals engaged in HIV care. And we'll need to think sort of flexibly about how to address those needs. Additionally, as another state issue, Texas state law prohibits syringe exchange services. But not only does this create a vulnerability in an infectious disease context, but also syringe exchange programs and syringe service programs can really provide sort of a comprehensive space to engage in testing and linkage to care and treatment. And finally, and this certainly isn't limited to Texas, and is probably the largest challenge, is the ongoing stigma and discrimination that communities face, including related to race, sexual orientation, gender identity, and HIV status. And it's probably the most difficult challenge here to address with sort of the tools of science that we have. Next slide, please. So finally, just to put some questions that we have on the table and things that we're thinking about and watching moving forward, the FY 2020 budget process. As Jen mentioned, it's looking good. We have the budget request from the President and the House and the Senate that sort of agreed to it, but we need that budget process to move smoothly in order for the dollars to get out into the streets as quickly as possible, and so we'll need to watch that. We need to look at what funding will look like in the future. We've been hearing that it's likely to increase, but that's never a sure thing. And so looking at what that level is and how funding is approached in the future will be important. As Jen mentioned, it may not be to the 48 counties, and so how that's delivered will be obviously critical to delivering services. Another important factor to think about is that the federal government is also updating the National HIV/AIDS Strategy, and that's happening in concert with the Ending the Epidemic Initiative, but they're separate documents, and so we'll need to see how they relate to each other and sort of the impact NHAS has on the initiative. One of the biggest challenges we've been thinking quite a lot about is the intersection with the initiative and some of the other Trump administration policies that sort of run counter towards the goals of ending the HIV epidemic in the U.S. And so some of the key ones we've already talked about, 1557, which is the proposal to remove sexual orientation and gender identity protections, a provider conscience rule, which could provide providers with the ability to deny care or treatment to an individual that is against their sincerely held religious or moral beliefs, the public charge proposal, which we talked about, broader threats to the stability of the ACA, and then shifts in terms of what Medicaid looks like and what private insurance looks like. So states that are introducing work requirements and the ability for non-ACA compliant plans, like short-term limited duration plans, that can actually deny people with HIV coverage or deny somebody who's on PrEP coverage and kind of return to what the private market looks like in a very limited sense, at least, for some of those plans. We mentioned this earlier as well. The biggest question is how are we going to address stigma, discrimination, and social determinants of health? while we end the epidemic. And then lastly, really thinking about what does this evolving landscape look like that we're living in, and how does that impact how we're delivering care and trying to meet these goals? So the healthcare landscape is shifting, or at least the sort of policy discussions around it are. As we look forward to the 2020 election, all of the Democratic candidates are really talking about Medicare for all or a single payer system, or really shifting how we deliver healthcare in this country, and that would have a dramatic impact on HIV care treatment and prevention. And similarly, the prescription drug landscape is evolving. And so we need to think about the impact generics, long-acting injectables, and policy changes that look at things like drug affordability could have on access to care and treatment. So that's it for sort of the issues and questions that we have. And unless you have anything to add, we'll turn it over.
We're looking forward to getting your questions.
Your questions and thoughts. So thank you.
Yes, sir. Oh, no, I'm on
Great, thanks, Ella. So we'll go ahead and open and ask the questions. If you have questions, you can type them in the chat or unmute yourself. I have a quick question going back to some of the conversation about the role of health centers and community health centers in the federal ending the epidemic plan, and flashing back to one of the really first Melissa, can you mute everyone else? You know, getting some feedback from someone. So going back to one of the first webinars at the federal level that came out when they were talking about pushing federal community health centers, and they quickly displayed like a really low stat on how many people living with HIV are treated by health centers. And so I know a lot of the administration is focused on PrEP and routine testing in health centers, but do you know, have you heard anything about plans or any direction or change to try and open up community health centers to treatment and taking more people living with HIV into their clinics for care and treatment?
A really good question, and the short answer is not particularly. You know, it varies. The role of community health centers on the treatment side does vary around the country. As you probably know, there are some FQHCs that are also Ryan White funded and actually originated as HIV sites. So those, of course, are, you know, big HIV providers and are very important in some places. But I think you're getting at a larger issue, which is, to date, in general, the nation's community health center network has not played a very big role in HIV prevention or care. And could this initiative stimulate that? Everything we've seen has really focused on the prevention and PrEP side. I think in part because there's an assumption that, you know, Ryan White is really, between Ryan White and insurance, that will take care of it. And in fact, the Ryan White dollars and insurance dollars can be used at community health centers. But we agree that there is a real opportunity here to engage community health centers, not just as a place to use their 340B programs to get PrEP, but really as a site for people that are living with HIV to be able to get the range of services that they need. It remains to be seen how much of an emphasis will be placed on that, but it's an opportunity that could be seized upon. We have not seen much in that yet. The stats on how many people with HIV community health centers are serving, it's a pretty small share of their client base. So short answer, not really, but there's a real opportunity. I don't know, Lindsay, if you have anything to add.
That's exactly how I would have responded as well. And just to add that I think the other opportunity that's there is really to ramp up testing in community health centers, because it's happening to some extent, but it could be a lot better.
And that may be something specific to, you know, your situation in your state. You know, some places have had much more difficulty engaging community health centers. So at least I think having this initiative as a high-level, you know, White House leadership-focused effort that is also going to be associated with new dollars does provide new leverage, really, to bring in the community health center network.
Thank you. Somebody else had a question?
Yeah, this is Shelley. I was intrigued by, well, I wasn't intrigued by, but I noticed that that you included the AETCs, and I was just wondering. I mean, obviously they're already helping to develop the workforce, but I was wondering if you had heard. Have they been given any sort of expanded charge or any particular direction, or is it just that they'll continue to do the type of workforce development they've always done?
So far as I've seen, there's been certainly a focus in including AETCs as part of this initiative, but I haven't seen specifics in terms of like infusions of funds to sort of support those activities.
But I think, you know, to connect the first question and the second, there's also an opportunity if that existing network could be used to do some of the education and awareness raising in new sites potentially. But we haven't seen that. This is good because we're going to write down these and flag them. Other questions?
Along the same lines, there'll have to be training of new ID physicians or PAs, things like that, right? If they increase the FQHC presence around HIV.
So just so I understand, you're basically saying the workforce, the ID workforce, the healthcare workforce, which we already know for HIV is not growing, it's shrinking, and increasing the demand side needs to increase the supply side too, for sure. And we have not, I mean, there is some workforce money in this initiative. There have been some efforts to mobilize a workforce in there's 3 sites where the public health workforce efforts are being mobilized, and I think there's an intention to do more, but it's recognized that that area is a real barrier for sure.
There was a question that came in through the chat from Aurelia asking if Ryan White funded providers, are there any incentives or incentivized to use rapid treatment or early access to treatment like Rapid Start? Do you know of anything?
So we have not seen I think this is the kind of, there's two ways that this could be done. One is to see what the NOFO, to look closely at the NOFO and see if it has any of that language in there. But I think this is, for better or for worse, this is the kind of thing a local jurisdiction, I think is being encouraged to, frankly, think differently about how to use these additional funds to do exactly that. So if we think that one way to really make a difference is to move to more of a rapid treatment model, which is where it's been done, it's made a big difference. But the biggest barrier to doing that is having the workforce or the other mechanisms in place to ensure that happens. If there are new funds coming into a jurisdiction, that jurisdiction could decide these funds above what we usually get could be used for exactly that. And I think that really should be the opportunity for local planning to figure out, is that where we want to, do we see that as the best way to use these new resources? And each jurisdiction may be a little different, but I haven't seen funding oriented around that kind of incentive, but I think that's implied.
Yeah.
Yeah, I don't know. I haven't seen the NOFO either, but I know that some of the early examples from our federal partners around the use of the new HRSA funds were specifically around Rapid Start.
Yeah, the NOFO is quite broad, and it encourages potential grantees to really think about what interventions and strategies might help meet the goals of reducing HIV infections. And so it's certainly possible that somebody could apply with that intention, with the intention to sort of really implement a rapid treatment and early access program.
And when we had a big event here at KFF with the federal government and also various local partners and advocates, Rapid Start was identified as a real need. And even in places where sort of outside of San Francisco and New York, where there have been resources to do that, many representatives there that day said that's a big challenge for them. So I think I'm glad that federal government has been talking more about that, because it's really not something where there's been a big emphasis and could make a huge difference.
So we have another question in the chat.
We can actually see that. Yeah, go ahead, sorry.
Okay, can you see them?
Yeah, the 18% increase, is this increase only for the identified jurisdiction? Good question. We believe for the most part, this new money is first phase money, first year money, and the administration has said it will be for the jurisdictions that have been identified. It doesn't mean 100% of it, because they'll probably keep some for some other things, but I think the bulk of it is intended to go to the jurisdiction.
It's dedicated to the jurisdictions, but technically that 18% number, that refers to the prior year's total funding level for CDC.
Right.
So it's such a significant infusion for those jurisdictions that it's actually bolstered the entire budget by 18%.
Right, so the additional amount, though, is for the insurance jurisdictions.
Exactly.
It's not, so the existing awards that places were getting, that, that's going to continue to follow the CDC approach to providing its prevention funds to states and localities, and this is above that. One thing that we don't know for both the HRSA money, the Ryan White money, and the CDC prevention money is what decisions or allocation choices will the federal government make for distributing that money. As everybody knows, most of the money distributed through Ryan White and also through CDC is done based on set criteria. And our understanding is the money that is being requested is going to be able to be allocated differently and outside of those criteria, for the very reason that there are going to be some jurisdictions that are going to need more than others. For various reasons. So I think that's something we don't know yet, but that's what we know, that the administration is intending to do that. Other questions?
So do we know a timeline for phase 2? I'm thinking of jurisdictions that aren't possibly part of phase 1, feeling that, they're not maybe part of this. Is there a timeline and any ideas of what phase 2 is to look like?
No, I've not seen a timeline. I've seen discussion of phase 1 both being the first 5 years and phase 2 being the next, as well as this is just year 1. These are just the 48 jurisdictions that we're looking at, or 50 jurisdictions for the first year. But my sense is that it's going to be a few years before, and I actually don't have specific information on that.
Yeah, and some of the funding announcements now will say this is funding for year 1 of a 5-year initiative.
Yeah, 5-year initiative. So the idea being that the jurisdictions that are getting funded will continue to get funded. I don't know, there is an intention to make this a more nationwide effort, but it's unclear if that means in year 2, does the 10 next jurisdictions come on, or do 20 more jurisdictions come on? Don't know. And frankly, in the budget environment that we're in, it will probably be important for the government to show some successes, which is hard to show, right? It takes a while, but to show some kind of movement that these additional funds have been able to have certain results will go a long way to be able to get to that second set of jurisdictions. But I think that's an important question to ask the federal government for sure.
Other questions from anyone?
Jesse.
Yeah.
Hi, it's Rosa. I guess my question is what kind of coordination can we expect among federal agencies across this rollout? for continuity efforts? Any ideas?
Yeah, so another good question. That's always been a challenge, right, for states and local entities trying to deal with multiple touch points in the federal government, different types of grants, different grant periods, different rules. Yeah, so we know, we are well aware. What we've seen so far is a pretty regular coordination at the high levels in the agencies that is more so than it's new. We have not, while there had been efforts under the Obama administration to pull the agencies together at HHS, I'd say this has stepped up to a different level because there's been such a mandate to do a better job, and people have, agencies have been empowered to do that. So it bodes well for better coordination. That is the intention, but how that translates to what happens after, in the true year one of this, don't know, but that is what the stated intention is. And I think that if it doesn't happen, that would be one area of it would be an unfortunate misstep, because this is a real opportunity for this to be done differently. And then one analogy, it's not a perfect one, but certainly when George W. Bush announced PEPFAR for global HIV in 2003, there was no real coordination at all happening in the federal government. There was very little happening in the federal government on the global front, and having that high-level announcement followed by new money with a real mandate was what made the difference in spurring action. So I think that's the hope here. But coordination, which doesn't sound as exciting as all the other things, we know is essential to the success.
And we're seeing it most closely with CDC and HRSA,
Yeah.
which, given the level of funding for those agencies, is probably the most important place for it to happen.
Right, good point. So most of the money is going to Ryan White, health centers, and CDC. So that's where the coordination should happen. We've seen that. I actually also sit on the CHAC, the CDC HRSA HIV Advisory Committee, HIV, STD, and Viral Hepatitis Advisory Committee, and I have seen it there as well. So just for what that's worth, it is happening. And someone is posting what it was said by the federal government itself last week about the NOFO, and that it will increase in subsequent years, 5-year commitment. Future years, the amount of funding available will increase dramatically. Just so people know, that doesn't mean that the $292 million is a 5-year amount. That is a 1-year amount. But I think the idea is that they're thinking about this phase 1 and that amount of funding as what what's going to look like for the first 5 years. But unclear, because we also heard at one earlier in the period of this year, they were talking about asking for $1 billion at some point. So.
Yeah, but this is true. As Jen mentioned, we've been hearing this from the very launch of the initiative, that the federal government anticipates increased funding over time. But I think it's just an important thing to watch. And of course, at the end of the day, it lies in the hands of Congress.
So I know some of the conversation that I've ever heard at a federal level is also, and I'm not sure about this new NOFA that's coming out for care money from HRSA, but I know there was discussion of money coming out outside of the Ryan White money, outside of the Ryan White allocation or the Ryan White program, in order to sort of move around some of the legislative requirements of Ryan White to create more freedom out in the field in terms of care, to do more innovation and maybe bring partners on that don't necessarily won't approach Ryan White money because of all the regulations and the rules. So it's a two-part question. Is the current NOFO, do you know, is it actually tagged as Ryan White dollars, or is it just care money that's being put out through Ryan White, through Part A programs, through HRSA's, through HAB? And two, what are the pros and cons in terms of your thoughts, or have you thought about, I think there's a good side of that, a very bad side of that.
Sorry. It is actually Ryan White dollars, and on the Target website, there's a recording of the HAB webinar that talks about the NOFO, and Laura actually addresses this and talks about how they use, they're using authority that still needs to be granted by Congress, so assuming Congress approves this, which they seem optimistic about, then they can use existing Ryan White dollars for this purpose, but can give more flexibility around it. And that's what I was alluding to in discussing the NOFO, around having a little bit more flexibility and not having to stay within the traditional service categories that a Ryan White grantee might used to be thinking about. One of the questions on that webinar was somebody asking if the funds could be used for testing, and she said that they could. So that's just one example of sort of innovative use of Ryan White dollars.
I mean, the other thing to add is in the budget request to Congress, HRSA specifically asked for so the money in the NOFO is 19 money that was already appropriated, that's being allocated for this. The new money there's 70 million for Ryan, that would be for Ryan White, specifically Ryan White money, but HRSA has asked Congress for the authority, or to waive the authorities that usually are in place that govern that money, so it can move it differently. And what that will look like is not known yet, but that could be some of the issues you're talking about. It would allow the agency potentially to have different allocation rules that it normally is subject to, which are very much specified under the law for the most part. It could allow the agency to provide much more flexibility to local jurisdictions to address some of the barriers that you are talking about. So that is going to be a really important part of this, and I believe that Congress is giving them that flexibility. So it's all going to be in what gets said in the subsequent grant announcements is going to be very, very critical here.
There are other questions from folks out in the field?
So any recommendations or insights kind of above and beyond what we've talked about that y'all might have for us in Texas?
I mean, this is not, a big aha, but I think if I was sitting where you are, I would try to force myself to say, what are the two or three things that I can't do right now that I really wish I could do, I think would make a difference, and if I had some new money and new freedom to do them, that's where I would focus. And to the extent that you can identify a couple of things, I don't think this is about doing everything that's been done before a little bit more. This is really about what is going to, be the kick, the real jump into a new level of intervention that's going to drive down incidents, increase access, retention, and those things. So it's a hard exercise. I'm not saying I could do it easily, but if you could have that focus decision or ideas, it could go a long way. So if a few jurisdictions, for example, decide, or a couple times, we're really going to focus on rapid start. Rapid start is what we think, then it's rapid start. Maybe for others it's, and maybe it's not one or the other, but it's got to be PrEP. Maybe it's something else. Maybe it's really the biggest challenge and the biggest area we want to address is increasing awareness among those at risk, because if we don't focus on that, we're not going to get people to come use the services that we already have. So each jurisdiction is going to have to, I think, do that hard question of themselves to figure out what would make the difference. And even if you do, like for example, let's say you decide housing is the biggest challenge. There's no new money here for housing, so it's not clear how that's going to. So this isn't going to solve everything, but it's an opportunity to keep the existing programs you have going, but do something different in a different way and more intensely, I guess. It's rare that you get that opportunity of additional funds to do things maybe a little differently. Often it's the same amount or less, and it's usually to do the same thing.
I think that brings up a good point, and you talked earlier. I know, looking at who's on the call, I know we've got some folks on the call from the 5 jurisdictions, from Houston, Dallas, Austin, San Antonio, and Fort Worth. And some of you are involved in the community and planning. I wonder if you know, within your own jurisdictions, if you can talk about what the plans are for the new NOFO, what your cities are fighting for, what your thoughts are in terms of using the new money. If anyone wants to speak up. I know, so I can address some of, at our level, some of the CDC new money that's come out for planning around ending the epidemic planning, and I know we've talked some about this. For 1906, the money flows through us for Dallas, Fort Worth, San Antonio, and Austin. So we've been working with those jurisdictions. We know that Austin, San Antonio, and Dallas right now are all fast track cities, so they've already are at different stages of developing and working towards ending the epidemic, and their plans in those jurisdictions. So we're going to be supporting those cities with their ongoing efforts and updating their plans. We'll also be working with Fort Worth and putting some funds in Fort Worth. A lot of this is going towards coordination and actually putting boots on the ground in those cities to do some of the work, to put forward and move forward their own local plan, and what needs to be an engaging community and those sorts of things. And then of course, it gets their funding directly. So they're doing some similar work in Houston using the new CDC planning money.
Great.
Are there any other questions from anyone? So I have one other care related question. I know, again, some of what I've heard from the federal level, and particularly around Ryan White, is that HAB is working to re-examine some of their policy decisions, possibly, that create some restrictions. So I know, for example, I've heard rumors that the 6-month eligibility check, which is legislation for ADAP, but they've applied to all Ryan White funds, that there's some possibility that that might be opening up, and for Ryan White dollars, they might not be requiring 6-month eligibility rescreening. Do you know, have you heard anything about that, or other HAB?
Yeah, it's a really good question. That has come up throughout this process. It's an ongoing issue, but it really was raised clearly to HRSA and also the HHS Office of the Secretary, that is a real barrier. And if they are truly interested in getting people, increasing the share of people in care, keeping them in care, that has proven to be a real challenge. So I know that they are looking into it. I don't know the status of it. We can try to find out what has happened.
So Justin from Dallas, who's with the Ryan White admin agency and planning council in Dallas, chimed in the chat that they just had a brainstorming session about the ET NOFO, and they're looking at ways to create more robust peer navigation and data sharing.
That's great.
Thanks, Justin.
I think that's exactly the kind of thing that could, that usually don't get the opportunity to do that. Maybe this would provide, the ability to do something much more like that and scale that up.
I agree with you. I like your recommendation earlier that I think all of us need to be taking the time right now to think about, if new money's coming, what do we use it for? Because the turnaround on a lot of this money is so quick. the way it's being put out, and you have to apply and get it out in the field, that there's not a lot of time to really, at the moment, think about it. So planning ahead and thinking about what our priorities are will smooth that out.
Yeah.
Mhm.
Yeah, Melissa has chimed in as well about how this money can be used equitably. I know we've had a lot of conversations about health equity and equitable access, and that ties into our next month presentation, which we'll be talking about our excuse me, our Achieving Together Ending the Epidemic measures, the 90-90-90-50 in Texas. Ann Robbins will be sharing an update on where we are currently, our baselines are, where we are on that, and some of how that breaks out with our priority population. So I think, yeah, Melissa, thinking about how we use new funds to particularly target populations, both in prevention and care, that don't have as much access, or maybe aren't utilizing or being reached as effectively as they should be. So yeah, I think it'd be interesting to think about care money and how you target, use money to really focus on, for example, linking and retaining particularly young Black gay men into care, and doing some robust and really intensive medical case management or peer navigation programs for
Yeah, that's great that you're doing that. You know, while I was being encouraging to like think about how to use this new money, and there's this great opportunity to think differently and do something different, you know, it's not, realistically, we know that the amount of money that's going to be made available is not enough to meet all the need. So I think there's recognition of that, but it's certainly a significant increase than what's been there before. So it's just, there's much more that could be done, but it's really the first opportunity in a long time to be able to make a different impact. And, you know, I think the administration should get credit for doing this. We also, you know, some of the other work we've done, a lot of the ideas behind this initiative did come from prior efforts under the Obama administration with the national strategy. So there's continuity there for sure. But you know, it'd be great to take advantage of the opportunity that's going to be present. And we'll know about the budget pretty soon. But like I said, it's quite positive.
Are there any other questions or comments? Okay.
You know, Lindsay and I are both happy to speak further with anyone or respond to emails if you have other questions.
Great, thank you everyone for joining us.
Thanks so much for having us.
Jen and Lindsay, and we will go ahead and start wrapping up. On your screen, I wanted to remind everyone, our next call will be next month on October 16th. Ann Robbins from our offices at DSHS will be sharing, again, information and a detailed breakdown of our 90-90-90-50 goals. I encourage everyone to be on that. There's some really great analysis on where we currently are, where we need to be, projecting out some points over the next several years on the goals and what we need to be trying to hit, both across prevention and care. So join us. If you haven't signed up, I encourage you to go to the Achieving Together website, which is achievingtogethertx.org. Check out the website and you can sign up to receive updates through that. And then you can keep up with this ongoing series as we do more of these conversations and who our speakers are and everything going on around ending the epidemic in Texas. And also, I should have had it up on the screen, but if you're interested, Achieving Together is also on, we've got Facebook, Instagram, and Twitter. So if you go to our website, you can find those links and sign up to keep up on the social media of your choice. So that, well, thanks, Robin, put the website in the chat. And if you are interested in keeping up and want to send your email in the chat and we can add you to our distribution list, you can do it that way as well. Again,
Jesse,
yes, ma'am. Yes.
this is Barry. I had a question. Will we get copies, or are we able to get copies of the slideshow that they just presented, or not?
Fine with us. Definitely.
Yeah, we can share the slide deck.
Great. Thank you.
We'll share it and we'll post it up in our Google Drive as well.
Yeah.
Great. Thank you.
Mhm.
Any other last minute comments or questions or announcements before we wrap up?
No, I included my email in the chat. If anybody wants to just reach out and share their contact information, we'll add that to the distribution list as well.
Great.
Whatever's easier.
All right. Thank you everyone for joining us, and super huge thanks to Jen and Lindsay from KFF for your updates.
Thank you.
Well, thanks for letting us, yeah, thank you. Great to talk with you.
Thank you.
Bye.
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 Bye everyone. Have a great day.
Just 1 second to make sure I copy this chat, and then I will log myself out. On to the next file. New.
Melissa,
Yes, hold on. I can't see my screen, so give me a minute. I feel blind. Hi.
oh, I'm going to go over with Elias, or are we on the same place?
Yes. I am going to check out of here.
Okay.
See y'all in a moment.
Yes, will do. Thank you guys. Thanks, everybody.